These lectures are not designed for use as medical references to diagnose, treat, or prevent medical or mental health illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or mental illness, you should consult your personal physician or other mental health professional.
The inspiration of poets, the curse of insomniacs, the boon of the young and far too often the bane of the elderly, sleep, renewal, restoration, or lack thereof, is one of the most common medical complaints seen in primary care clinics today. Unfortunately, we're all getting less sleep, and chronic insomnia is on the rise. The pharmaceutical industry has seen the need, and they're busy at work churning out sleep medications while making a fortune. Are there other options? Can CBT help? Let's take a look and see. Now, we've all been there at one time or another, the tossing, turning, churning of a restless night, then waking up still feeling kind of exhausted the next day. Sound familiar? Fortunately, problems sleeping are often temporary. You might be stressed at work, maybe you're having a flare-up of your back pain, or you're replaying a fight that you had with your spouse. But for some, insomnia becomes chronic. It's night after night after night of not sleeping, until eventually going to bed is something to dread. Insomnia is defined as difficulty with the initiation, maintenance, duration, or quality of sleep that results in the impairment of daytime functioning, despite adequate opportunity and circumstances for sleep. Most research studies adopt an arbitrary definition of a delay of more than 30 minutes in sleep onset or a sleep efficiency of less than 85%. Now, your sleep efficiency is simply the ratio of time asleep to time spent in bed. Fewer than half of Americans say they get a good night's sleep on most nights, and 10% have chronic insomnia, with chronic being defined as lasting more than 1 month. We see higher rates of insomnia in people with chronic pain, psychiatric disorders, alcohol or drug use disorders, and the prevalence of insomnia rises with age. In 2017, McKinsey estimated the U.S. sleep industry to be worth $30 to $40 billion a year, which includes sleep clinics, some of which are spas, conducting overnight tests for sleep disorders, like apnea, includes prescription medications, over-the-counter medications, herbal sleep aids, how-to books, sleep-encouraging gadgets and gizmos, including new spooning robots and vibrating weighted blankets. Unfortunately, most of these gizmos just don't work. Let's first look at sleep medications. Now, there are about 50 million prescriptions for sleep aids that are written per year, equating to about $4 billion in prescription drug costs. Now, sleeping pills fall into a number of different categories. The first are the sedatives or hypnotics, and these aren't used so much before. These are the heavier type tranquilizers. The next category are the benzodiazepines, and unfortunately, these are still used, and they are habit-forming and have a lot of side effects. Things like Halcion or Restoril fall into this category. Even more common are the benzodiazepine-like drugs, or benzodiazepine agonist, drugs like Ambien, Sonata, or Lunesta. Things that can give us maybe 3-4 hours of kind of sleep, but might not give us restorative sleep. Older antidepressants are often used, not because of their antidepressant effect, but because many of them make us drowsy and help us go to sleep, and probably the most common one that's used is a drug called trazodone. The last category are the over-the-counter drugs, and this is also a big industry that makes a lot of money. The most commonly used is diphenhydramine, also known as Benadryl, and that's an older antihistamine. It is the active ingredient, or at least the ingredient that makes you sleepy. That's in Tylenol PM or Advil PM or those types of drugs. People will also take melatonin, they'll take valerian, an herbal sleep aid, or even sometimes they'll use lavender, or at the hotel, there was a little bottle of pillow spray that had a lavender scent to supposedly help me sleep better. Although the bias and the preference usually are for pills, several well-designed studies show that pills are not more effective than psychological interventions, and they have side effects. So what are some of those psychological interventions? Now, the leader of the pack is something called CBT-I, where the I stands for insomnia. It's a well-researched, evidence-based treatment that's short-term and impressively effective. But before we dive into CBT-I, I wanted to mention a few other options. Now, although these aren't used that commonly anymore, they are still sometimes used, and you will see that part of them have been incorporated into the broader package of CBT-I. The first is something called stimulus control therapy, where you go to bed only when you're sleepy, you use the bed only for sleep and sex, and you get up if you're not asleep within 30 minutes. So the idea here is you don't want to pair your bed with feeling frustrated or disappointed that you're not sleeping, or maybe anxious about how you might feel the next day. You're not sleepy, you're not sleeping, get out of bed. The second is sleep restriction therapy, and this is probably the least popular of all, even though it is effective. And here you reduce the time that you spend in bed to your estimated total sleep time at baseline. So if you only get 4 hours of sleep on average, that's where you start, and you don't allow yourself to stay in bed for more than 4 hours. You then increase by 15-minute increments each night, as long as your sleep efficiency stays at 90% or above. So night 2 would be 4 hours and 15 minutes. Night 3, 4 hours and 30 minutes, and so on, as long as that sleep efficiency stays at 90%. You can probably see why it's not that popular. There's also a number of relaxation therapies or somatic quieting interventions that might help our body get into a better state where we might be able to sleep. Things like progressive muscle relaxation, breathing exercises, or guided imagery. But really, your best bet is CBT-I, which includes elements of a lot of these other treatments. But do these treatments work? Well, in head-to-head trials comparing CBT-I with sleep medications, CBT-I is the clear winner for both short and long-term outcomes. In fact, CBT-I is one of the rare behavioral therapy interventions that makes it into the Journal of the American Medical Association, a publication that's not known for its psychological mindedness. So let's take a closer look at what a 5-session program of CBT-I might look like. First, session 1. This will be basic education about insomnia, about CBT-I, about the treatment program. We might want to begin a sleep log, and you should think sleep monitoring, and we might give out a reading, an educational reading about something called sleep hygiene. More on that in just a moment. Session 2, here we want to measure, calculate sleep efficiency, and we'll do that by looking at the information gathered in the sleep log. We might talk about sleep restriction. Again, we don't want people tossing and turning and developing a negative association with being in bed, so we might shrink down somewhat, not extremely, but somewhat the time spent in bed. More on that in a moment. Session 3, we'll talk about sleep hygiene behaviors. What's being done, what's not being done, what might get in the way. We will probably want a fairly detailed assessment of sleep hygiene behaviors. Then we'll want to set some goals regarding the ones that aren't being done or aren't being done completely. We might need to do some problem solving if it's hard to get those sleep hygiene behaviors in place. Session 4, we're going to start looking at thoughts. And here we're going to break out thought records, specifically automatic thoughts about sleep or the consequences of insomnia. Session 5 is where we go back, we see where we encountered some difficulties, some obstacles, and we begin to solidify, practice, and elaborate those same skills. Now, in the spirit of this course, rather than just talk about CBT-I, let's see it in action. To do that, I'd like to introduce a new case, the case of Christian, who will follow just for this lecture on insomnia. Christian is a 35-year-old single man with a 7-year history of insomnia. He usually has trouble falling asleep, and he can toss and turn for hours before becoming exhausted enough to finally sleep. Although he doesn't have any pain or any known medical conditions, his mind is usually racing when he goes to bed, and he can worry a lot. He's tried relaxation training, he's tried breathing exercises, he tried meditation, and he often uses over-the-counter medications like Tylenol PM. He's never seen a doctor, but he read about CBT and he wanted to give it a try. As always, we first start with assessment and goal setting. Given the wide range of causes for insomnia, we'll want to first know about any additional problems that might be contributing to his insomnia or might make treatment more difficult. So common culprits might include untreated depression, having an anxiety disorder, chronic pain, or maybe a substance use disorder. We might also uncover significant life stressors like job loss, trauma, or a death in the family. Fortunately for Christian, this looks like a fairly straightforward, although long-lived case of early onset insomnia. He has trouble falling asleep, but once he's asleep, he's usually good for the rest of the night. But remember, he's noticed that his mind is racing when he goes to bed, and he can worry a lot. He doesn't meet criteria for generalized anxiety disorder, but we might bookmark this for later. If CBTI alone doesn't do the trick, then we might roll out some of our other CBT tools for worries. Remember strategies like scheduling worry time or keeping a worry journal by your bed from Lecture 7. But let's try standard CBTI first. Now, after the screening and assessment, the next step is usually some education and some self-monitoring, in this case, a sleep log. I'm sure this sounds familiar by now. Education can include the basics of sleep. What is it? What's it for? But it most commonly focuses on something called sleep hygiene, a set of structured, concrete recommendations that have been proven to help with sleep. Let's pick up the session with Christian, where he fills us in on the details of his struggles with insomnia. Well, let me start with how did you sleep last night?
I did sleep well last night, actually, but I think that may only be the case because I took some sleeping pills.
Okay, all right. And I see here from your chart that it's Tylenol PM.
It is.
So your the main ingredient is Benadryl or diphenhydramine, which is an older antihistamine that helps people to sleep.
Okay.
Is that something that you take every night, or?
If I can, sometimes I'll run out and I'll forget to go get some more. And if I do, then I really won't get much sleep. But there are also times where I'll take it and I still don't get any sleep.
Okay. All right. And about how much of that are you taking usually?
2 pills per night.
2 pills. Okay. So that's I believe probably about 50 milligrams or so of diphenhydramine. Okay. So we'll keep that in mind, and I think ultimately our goal will be to help you go to sleep naturally,
Okay.
and to sleep naturally, and to not have to take something like that.
That'd be great.
Does that sound?
Yeah, sounds
Okay,
great.
So something to work for.
Yeah.
So let's do a little bit of an assessment. And I know you filled out your surveys already about your sleep. From what you've said, and I just want to double check this, it looks like your biggest difficulty is going to sleep at night. And once you do get to sleep, if you get to sleep, then you're able to stay asleep until your alarm goes off in the morning. Is that correct?
Yeah, very correct.
Okay. And while you're trying to go to sleep, what is it that's happening usually? Like, what's keeping you up?
It's just that a lot is on my mind. I think I may be too stressed. I'm always thinking about something, and it's hard to clear my mind so that I can actually fall asleep.
Okay. Okay. So you go to bed. Sounds like there's a lot of mental activity still,
Yeah.
even though your body is shutting down
Yeah.
and you're in bed trying to relax. Your mind's still going with the leftovers of the day or
Right.
the stressors that you're dealing with.
Yeah.
Okay. And what do you do with that? Do you talk yourself down? Do you do breathing exercises, or what?
I've tried to do some breathing exercises, but I've also had some issues with that, even trying to just count to 10 and to calm myself down. I've tried to just calm down my body and relax my muscles, and I get distracted very easily. Those thoughts in my head, the stress will come back, and it just keeps me awake.
Okay. All right. And for someone with a 7-year history of insomnia, I would guess that you've had a few assessments, maybe talked to your doctor before. So tell me your history, I guess, of wrestling with this.
I actually haven't talked to many people about this. I haven't seen a doctor or anything for this issue. And I've just been trying to deal with it myself, and I haven't been very successful with that.
Okay. All right. Well, I think it's probably a good idea for us to get you to at least see your primary care provider, and I'm happy to facilitate that connection. And I'll say, you know, in the model that we use, we want to look at potential biological causes of insomnia, but also psychological and potentially social causes of insomnia. Psychological and social, way more common, but you might as well look at all of them at
Yeah.
once to make sure that it's not something like sleep apnea. Sometimes when people snore at night, it keeps them from sleeping more deeply and they feel exhausted the next day. So we just want to rule out things like that while we're still working on the cognitive behavioral therapy.
Okay.
Does that sound all right?
Yeah.
Okay, all right. Okay, so he's clearly motivated to try something. A few red flags popped up for me in that vignette. First, he's using Tylenol PM. There are certainly worse things, but I wonder about psychological dependence despite its side effects and limited value. We'll need to explore whether or not he feels comfortable testing out a period of time when he doesn't use it at all. Second, I hear a lot about cognition, worry for sure, but I'm guessing that after 7 years of frustration, he's developed some pretty strong and possibly biased thoughts about insomnia and his ability to control it. The first thing we'll want to do is to talk about sleep hygiene. He probably knows some of this already, but it's worth going over every point to make sure he's putting them all into action. The possible pitfall here is him cognitively understanding the recommendations, but then not putting it into action. It really happens all the time, particularly around sleep restriction. But let's go through the sleep hygiene list, and I want you to think about how any of these might apply to you. Number 1, go to bed only when you're sleepy. And note that feeling sleepy and feeling tired are not the same thing. Number 2, keep the same wake-up time every day, including weekends, no matter how much or how little you slept the night before. Step 3, maximize your sleep environment. You want to keep your bedroom quiet, comfortable, and dark. You might consider using white noise. And if you're someone that looks at the clock a lot, you might want to hide the clock. Number 4, have a wind-down routine before bed. This might include relaxation or a relaxation exercise of some sort or a warm bath. 5, you want to get regular exercise, but not within an hour of going to bed, as that might be too arousing. Number 6, don't nap during the day if you can help it. If you do nap, keep the naps before 2 p.m. and limit them to no more than 30 minutes. 7, don't lie in the bed for long periods of time, feeling worried, anxious, or frustrated. If you can't sleep, it's okay, but within 30 minutes or so, you need to get out of bed and to do something relaxing. We don't want you to pair your bed with tossing and turning and distressing emotions. Only return to bed when you're feeling sleepy, and remember that feeling sleepy and feeling tired are two different things. Number 8, only use your bed for sleep or sex. No sitting in bed working on that last document for work. Number 9, limit your use of alcohol, caffeine, or nicotine, and remember that lots and lots of those new energy drinks have lots of caffeine in them. 10, you should limit your screen time at least 1 hour before bedtime. This includes TVs, it includes cell phones, it includes iPads, anything with a screen. We learned from Christian that he regularly uses energy drinks and coffee after a sleepless night. Caffeine can play an important role, but no caffeine within 6 to 8 hours before your usual bedtime. We also learned that he binge drinks 5 to 7 drinks per night on occasion, but he has no awareness that this would be considered a binge. He's also unaware of the effects that alcohol has on sleep. In general, alcohol helps with sleep onset. It might make us sleepy. However, it interferes with sleep quality and it interferes with sleep duration. It'll help you get to sleep, but you're not going to sleep that well, and you'll probably wake up in the middle of the night as your body, your liver, keeps processing that alcohol. We learned that he regularly takes Tylenol PM, and he's going to the gym already 4 times a week. He does not have a regular bedtime, and he tends to stay in bed for long periods on the weekend trying to catch up. He does not get out of bed when he's tossing and turning because he assumes that lying there will use less energy than getting up. When he calculated his sleep efficiency, the time he's asleep divided by the total time he spends in bed, he was only at about 65%, not even close to our 85 to 90% target goal. So you can see that our first steps will be to maximize sleep hygiene with Christian. Now, none of these recommendations are complex, but most people have trouble complying with them, particularly the ones about having a regular wake-up time, limiting naps, and getting out of bed if you can't sleep. I like to run these as behavioral experiments so people can have their doubts, but at least test them out. As with CBT for other problems, we'll need some way to monitor progress and to gather some daily data. We'll again use self-monitoring, in part as a way to limit the biases we all have in recalling things we might be upset about. Someone who is upset about their insomnia will be a less accurate reporter unless we have them write it down on a self-monitoring form. For pain, we searched online for a pain diary, then made some adaptations. I would recommend doing the same thing for insomnia, but here it's called a sleep log. Go ahead and do another Google search for a sleep log. If you don't find what you want, specify a CBT sleep log. Remember to try the terms public domain too, and to look in the image search for screenshots. Let's go back now to Christian and explore his use of a sleep log. So Christian, I think in order for us to get to the bottom of this and to really help you get the sleep that you need, it's important that we collect data, and specifically that you collect data about your sleep in an ongoing way. We don't want to make it too burdensome, but we do want to get information about a couple of key factors that we might be able to change.
Okay.
So I have a printout here of what's called a sleep log, and it's just a sleep diary, a sleep record. You can see that there's a column for each day of the week across the top. So you're going to do this. Most people do it in the morning, so you don't want to be logging things in the middle of the night.
Right.
But up in the morning when it's still fresh in your mind is usually a good time to do it. So each morning you'll just write down the date, and then you'll answer these 11 questions. So here it's what time did you get into bed? So you need just to be aware of when you're going to bed. And what was the recommendation for when you go to bed? Do you remember?
Just when you're feeling sleepy.
When you feel sleepy, you got it. You got it. Your autopilot tells you 11:30, right? But it's not 11:30. It's when you feel sleepy. Okay, good, good. And the second is, so what time did you fall asleep? Now, it's, again, one of those things you want to be aware of, but if you can't remember, you can't remember, and that's okay. It's not something to worry about. So the third, in total, how many times or how long were you up in the middle of the night? No, that's not usually your thing, but if that does happen, we want a record of it. And then it has you record when you got up in the morning, total time in bed, total time asleep, and then calculating sleep efficiency. We talked about that, and sleep efficiency is just the total time asleep divided by the total time in bed, and that will give you a percentage. And we wanted you to be at about 90% or more, but you are wherever you are right now, and that's just our starting point. So it's a good idea for us to have an idea of where your starting point is. Then you rate the quality of your sleep. Sometimes you can have a short night of sleep, but you slept really well. Other times, you maybe slept the whole night, but it was kind of shallow sleep. So rating the quality, then it will ask you if you napped, and then there's a place for comments. Comments is where you would include things like you had a lot of caffeine that day, you worked out right before bedtime, you went out with friends and had some alcohol, you took Tylenol PM, or anything that might affect your sleep. We just want it to put it in that last category. So any questions about doing this?
No, I think it's pretty straightforward.
Okay. Can you think of any obstacles that might come up that would prevent you from doing this?
I don't believe so. I think I will be set, and I should be dedicated to doing this.
Okay.
Yeah.
You seem pretty motivated.
Yeah.
And that's fantastic. Get as many days in there as you can between now and when we meet next time.
Okay.
If you miss a day, that's okay. Just make sure you get it.
Yeah, I'll try my best.
The next day. If you find that you do forget, you can also set a reminder on your phone so that whenever you're already up in the morning, it sort of pings you and it will tell you to complete your sleep log.
Okay.
Okay?
Will do.
All right. So you'll fill this out between now and next week. When you come in with the data, we'll look at it and see what kinds of patterns we can see.
Okay, great.
Okay, great.
Thank you.
Okay, so now we have some baseline data about Christian's insomnia. We have some targets to improve for his sleep hygiene, and we have a way to collect daily data on his sleep, the sleep log. Remember that you need your sleep log to get a more objective look at what's going on. So just to recap, here are the elements that you'll need. You're going to need time entering and leaving bed. You're going to need sleep onset latency, so how long it took you to fall asleep. We're going to need the number and duration of awakenings during the night. We need the time of final awakening, when you last get up in the morning, whether or not you took a nap, maybe a 1 to 10 rating of the sleep quality that you had, a 1 to 10 rating of daytime sleepiness, whether you took any medications, how much alcohol, how much caffeine, and we want you to be able to calculate your sleep efficiency, time of sleep divided by time in bed, and sometimes people times it by 100 just to get to that percentage a little quicker. So we're already more than halfway through CBTI, and really much of the remaining work is in improving compliance with sleep hygiene. But there's one last CBT tool we need to bring out so we can tackle Christian's ruminations, the CBT thought record. Let's take a look. So Christian, why don't we switch gears a little bit and look at the homework that you brought in today.
Okay.
You are going to begin a thought record that captured a triggering situation, the emotions that you felt and the intensity of emotions, and then the automatic thoughts that happened to bubble up.
Right.
So were you able to do that?
I was.
Okay, fantastic. So why don't you show me what you have?
Okay.
But before we get into the specifics, tell me why you would want to do that. Like, why would that be helpful? You want to sleep, right? So why are we talking about thoughts?
I want to actually know what's going on in my head when I'm trying to fall asleep. I want to know what the issue is. And maybe writing that down and knowing I can tackle that issue, maybe change my state of mind.
Right. So it's a really common problem that people have when they have chronic insomnia. Their thoughts sort of take on a life of their own and make it more difficult for them to fall asleep because they develop this worry about not sleeping, which makes them sleep less, ironically. So you've had that experience many, many times before, and the process of taking it out of your head and putting it on paper forces us to slow down, but it also captures the thoughts for us, and it gives us an opportunity, a working space where we can work with those thoughts and maybe rewrite them and help you to rethink them, and ultimately to change the way that you feel about them.
Okay.
Okay. So show me what you wrote down. What do you have?
So during the situation, I was just lying in bed and trying to sleep.
Yep.
And I noticed that my mood, once I wasn't able to fall asleep, I was becoming really frustrated and anxious.
Okay.
So what I was thinking, my thought process.
What was the intensity of those emotions?
80% frustration and 60% anxiety.
Okay. And just a reminder, we quantify those because after we finish the exercise, we'll have you re-rate them, or the next time this happens, we'll have you re-rate them. And we want those numbers to come down because ultimately you want to become good at wrestling with thoughts so that you're better at regulating emotions. And the best way for us to know that is to have you rate them. Okay. So we have a 60% anxious and a 80% frustrated.
Right.
Okay. And what were the thoughts that you got?
Well, I thought that when I woke up in the morning, I was going to feel awful. I was just going to be completely out of it, not going to be able to work properly, and I just thought I was never going to get sleep.
Okay. It's
just a reoccurring situation, so I could just get really upset and frustrated, and I don't know what to do.
Okay. So the thoughts, if we want the exact words we have, I'm going to be wrecked. I'm going to be wrecked tomorrow. Okay. Not a happy thought to have.
I'll never get to sleep.
I'll never get to sleep. And what's the third one? Why do I do this to myself?
Yeah.
Okay. So some self-blame in there, as if you're doing it on purpose.
Right.
Okay. And again, all really common thoughts. So why don't we think a little bit about the second half of the diagram? So in the first column, you had the situation. Second column, the emotions. Third column, the automatic thoughts. Now we're going to look at evidence for and against, and then we're going to try to rewrite those thoughts and rewrite those emotions.
Okay.
Now when I say evidence, really it's reminding us that thoughts we have are not facts necessarily, they are opinions, they are interpretations, right? And we have habits of mind or things that we typically think or ways we typically see the world, and sometimes it helps just to take a step back and go, well, wait a minute, is there another way to see this? Is there another way to think about this? Is there another set of information out there that I'm not using that might help me feel a little less frustrated or a little less anxious. So which of those three thoughts would you say is the most charged, is the hottest thought?
Frustrated.
Frustrated.
Being frustrated.
So that one's the emotion. And I'm going to give you my clipboard and let you do this in your handwriting and in your words, because then it's going to stick in your mind a little bit better. See if you can finish the next 3 columns for Christian. Try the evidence for and against approach, then rewrite the thought. After that, try a few other strategies. Think of decentering. Think of habits of mind and linguistic techniques. After a few rounds, Christian was able to pull up some evidence against his hot thoughts. He remembered that he's had insomnia for 7 years, yet his work evaluations have been consistently good. Even though it stinks to be so tired all the time, he's proven that he's remarkably resilient. He was also able to use his sleep log to find at least a couple of nights per week when he slept okay. Remember that free-form recall is fraught with errors, which is why we have the sleep log. He was also able to reframe the problems of sleeping as a challenge. He's now fully using CBT-I. Once he came off of the Tylenol PM, he realized that part of his daytime grogginess was a side effect of his medication. He's still exercising, and he's still trying to maximize the sleep hygiene recommendations. If you'd like to learn more about CBT-I, there are several free manuals online, again found with a Google search. You might also try downloading the free CBT-I mobile phone app put out by the VA medical centers. Just go to your app store and search for CBT-I Coach. In our next lecture, we'll pull together all we know about CBT and managing medical illnesses to talk about CBT and the beginning of the end of life. Thank you.